Yeah.
Yeah. And I think that's fantastic that you guys take the time to really get to know who the patients are. I know that had like kind of changed the patient-centered care back in like maybe the 70s. And then now it's just, so focused more from just the physician focusing on patient-centered care to the actual nurses and structural coordinators. So, yeah, I just wanted to push out a little statistic that kind of helps our community understand why it's so important for shared decision making to be a part of your health plan. So, according to the US Department of Health and Human Services, 35% of people have a basic or below basic health literacy level. And so then only 12% of adults have proficient health literacy, meaning they're not going to really understand what those health terms are. So the fact that you're putting it into layman's terms or something that I might be able to understand or someone else in my family might be able to, even with that language barrier, is so important. And so I just wanted to make sure we shared that with our community.
Yeah. I mean, we go to school for a long time to learn these terms. So there's nothing wrong with, people, everyday people not understanding. I think that's totally reasonable. I'm sure, Brooke, you agree.
Oh yeah, we dial it back, way
Yeah.
back.
So are there certain factors then that affect this conversation of shared decision making for particular patients? Let's start with Kristen.
Yeah, so there definitely are factors. There's multiple factors, right? When I first meet the patient on the phone, like I said, I'm like a detective, right? I get the notes from the referring provider. I kind of am putting the picture together of who this person is.
Hmm.
I even write it down, right? So I put their risk factors, their age, their weight, all these different factors. And I kind of have an idea. And then it never fails. We could be fooled very easily, right? You could say, oh, this is a 65-year-old who probably should have surgery. And you could have that idea in your head. You could sell it to your doctors. And then the person could walk in and you look at them and you say, they may be 65 on paper, but they look like they're 85. And we call that the eyeball test here in the clinic. It's like a term we use, a lot of us use. I say, go give them the eyeball test. And the eyeball test is basically, would you operate on this patient? Do you feel the patient would do well with surgery? And sometimes it's not straightforward. And sometimes it says, well, I could get them through. Well, if you could get me through, I probably would prefer to have a TAVR where you could get me through.
Right.
Or, you could look at a person and say, no way, they're never gonna survive this. Let's talk about other options. So, the eyeball test is really important. That's why we meet every patient. We want to see them walk in. We do little walk tests with them just very casually to see. We talk about what their daily life is like at home. So if they are mostly just sitting there in a wheelchair and their quality of life is that, that's a very different conversation than someone who plays tennis every day and just suddenly started feeling winded.
Right.
So definitely their quality of life, what their expectations are, and set realistic expectations. We see that a lot with people who have dementia or memory impairment. The procedure we perform is never going to make that better. And I think it's important that the family and the patient themselves understand that portion of it. So I think all those factors are really important in what we recommend and ultimately, the decision of the patient.
Wow, that's excellent. Brooke, did you have anything you wanted to add from maybe experiences in your life?
Yeah, I mean, she hit it nail on. I mean, it's a lot that goes into the workup for our patients, and it's very time intensive. And the patient, you have to understand all aspects of life that they walk. They may not have kids who can take care of them after surgery. They may only have home health coming once a week, and no grandkids. So you have to
Mhm.
understand all of these things, and lay it out for the patient so they know what to expect.
So let's start with Brooke to see what it's like, those differences between the community hospitals versus a large volume center.
I think the concept is essentially the same. It's always patient focused, and we keep the patient at the center of their decision making. I mean, it could be easier to get quote unquote lost in a larger hospital system, maybe, or a heart program. But, that's where the valve program coordinator comes in. We keep the connection between the patient and family and their physicians. And everybody's on the same page all the time. We have a conference once a week with our whole team, and we talk about the patients who are coming up for surgery, and maybe the patients who need to identify whether they're, a structural patient or a surgical patient. So we have these meetings so everybody can stay on the same page, and it's ultimately our job to ensure that the patient and family, is at peace with every decision that's made, regarding their care. What do you think, Kristen?
Yeah, I agree. So where I am here in New York, it's a very large center, and I try my best to kind of provide this concierge medicine where patients should feel like they're my only patient when it's their turn, right? I call everyone by their name. They know my name, get my phone number the same, and I could have a million things going on, but at that moment, that's the patient that we're concentrating on. And our team has the same approach, and there's standards across the United States that Brooke and I have participated, many other valve coordinators, in kind of really creating a standard of care for these patients, and really making shared decision making a standard of care, which now it is. So it's a patient's right to really know all their options that are available, and if a site can't provide adequate options, then we're supposed to refer them to a site that can. So I think having a standard of care like that should make people feel really comfortable that their facility, whether large or small, is performing up to the standards.
Absolutely.
Yeah.
Agree.
I just have one last question to kind of bring it all back to HeartSense. And so during a community heart screening, how is shared decision making happening during those type of events?
So at our hands-on heart screenings, where we screen for various problems from AFib to valvular heart disease, or even carotid stenosis, I think the most important part of being out in the community is the education portion and the hands-on assessment that the patients receive out in the community. Just to be able to sit and talk to a provider or a nurse about what's going on with you and getting a tidbit of advice, goes a really long way. And some of these patients in our rural areas, don't have access to a robust heart program or a structural heart physician. They may not even have access to a primary care doctor. Yeah, so we try to do screenings in the more rural population so we can capture those patients and be sure they get the care they receive.
They're lucky to have you, Brooke.
Yeah. They're so lucky to have HeartSense in the community in Baton Rouge. And now it seems like we're also expanding access to Lafayette coming up soon. So everyone stay tuned for that information. Well, this has been a fantastic discussion, and to be able to learn more about shared decision making and how important it is to, me and everyone else in the community that's watching this today, how important it is in their lives, and then also to have you guys part of that process. So thank you.
Thank you. Thank you, Kristen.
Thank you.
Yeah.